Ruptures that occur on a previously scarred uterus, again, they tend to be less violent, not as traumatic. VBAC mothers may possibly be on the higher end of the spectrum when it comes to the amount of time that is needed for a cesarean to take place if there's a uterine rupture. Just because and that's because it's not as violent of a rupture, because this and so it means that the baby may not be in quite as much danger if you're having a rupture at a scar site, because again, those tend to be less traumatic and violent. Now, going back to, you remember our lecture on induction, and we talked about misoprostol, which is also known as Cytotec. Uterine rupture cases that are caused by misoprostol or forceps tend to be riskier and more urgent. So again, there's been some better sort of policy in place on the use of Cytotec, and it is not recommended for women who are undergoing a VBAC, who are trying for VBAC, to be induced with Cytotec because it has a stronger risk of of not only a uterine rupture, but a more violent uterine rupture. And forceps, that's another thing you have to watch for. If you're attempting a vaginal birth and, and the doctor starts saying, hey, we should use forceps here, forceps do carry a risk of uterine rupture. Even if you have no previous cesarean section, use of forceps carries a risk of uterine rupture. And those types of uterine ruptures, again, they tend to be more violent, more traumatic. Baby probably has less time to a cesarean. Now, the interesting thing is that those circumstances, Cytotec and forceps, are going to take place typically in hospital because inductions with Cytotec take place in hospitals and midwives don't use forceps. So I suppose if you are undergoing a birth with those, you will be in a hospital, and hopefully the C-section will take place in enough time. On the other hand, if you're undergoing a home birth or a birthing center, and you are laboring naturally, you're not going to be exposed to those types of risks. And so if you're starting to have a uterine rupture, it's going to be less violent and there could be more time to transfer. So some of the perceived risks of, how long is it going to take to get to the cesarean may be balanced out for moms who labor outside of a hospital with the fact that the odds of them having a traumatic and violent uterine rupture are less than a woman who has an induction with misoprostol or has forceps used on her during birth. Okay, so we've talked a little bit about cesareans, when they're necessary, when they're not. Let's talk a little bit about VBACs and special scars, because this is another one that is kind of an interesting issue that isn't being talked about very much, and especially in medicine. So we've heard that you have to have the perfect scar. Well, not the perfect scar, but there are only certain types of scars that you can do a VBAC with. And this has been based on some research, but there are some limitations to this research. And this has been a little bit of a subject of interest to me because I found out that my mother-in-law had a classical incision with her first baby, which is typical for the condition she was undergoing for placenta previa. Classical incisions typical for that. And she wanted to try for a VBAC. And she was told that it was too dangerous and the insurance wouldn't cover it, and so she had 4 C-sections instead. Now, mind you, this was back in the 1970s, 1980s when she was having her C-sections. And so it was a little different in some ways. But classical incisions are not used very often anymore. But in cases of emergency, like with my mother-in-law, they are the cut of choice. Now, women with classical incision scars are generally not considered to be good candidates for VBAC because these scars are said to be more likely to rupture. Now, there is a certain amount of controversy on the likelihood of uterine rupture with a classical scar. So there was a study, Rosen et al., and they reported an 11% uterine rupture rate for classical scars. Now that's 3 out of 26. 26 VBACs with a previous classical scar, and 3 of them ended up in uterine rupture. So, and that's in concurrence with the 4 to 9% uterine rupture rate that is traditionally reported by the American Congress of Obstetricians and Gynecologists for these types of scars. However, here's the however, there have been other studies showing much lower rates of uterine rupture for classical scars. Landon et al. Reported a 1.9%, 2 out of 105 rate of uterine rupture in women with previous classical inverted T or J scars. Now, again, that number, 1.9%, that was 2 out of 105 of these VBACs where the mother had a scar that was supposedly not a good scar for VBAC and supposedly more likely to uterine rupture. Now, Chohan et al. Reported an even lower rate. We're going to go even lower, 0.64%, not 64%, 0.64%, 0.64% for 157 women with classical incision scars. So there is some great potential here. If we can get the medical community to kind of understand some of these things. Since Chohan also reported a 9% rate of asymptomatic scar dehiscence, which means asymptomatic, there weren't any symptoms, there wasn't any, big red flags going on. Many incidences of scar dehiscence in other studies may have been misclassified as uterine rupture, leading to the widely varying numbers. Now, scar dehiscence is not the same thing as uterine rupture. Scar dehiscence is where the scar kind of comes a little bit undone. It's not like explosive. It's not as traumatic. It's not as violent. It's different than a uterine rupture. But because they found that these asymptomatic sort of scar dehiscences were happening, but they may have been classified as uterine rupture, and that's throwing off the numbers. So when we look at this data set and we're being told these numbers of, it's just so common for a classical incision or, these other types of special scars to result in a rupture, they might result in scar dehiscence, which is not the same level of damage. And this is an area that really needs to be explored further. Again, it's a women's health issue, because if it really is true that these sorts of classical incisions have a less than 1% chance of injury, of uterine rupture, then we need to be allowing more women to have VBACs. And if you are undergoing a VBAC or want to undergo a VBAC and you have a special sort of a scar, your options may be more limited, but I would suggest that you try to talk things through with your OBGYN, maybe present some research on it, and get some feedback on whether, because if the only thing is that the only reason they're saying you shouldn't try VBAC is that you've had a classical scar or maybe one of these other special scars, then you might possibly be a good candidate. You might have to do some fighting, but it sure can't hurt to open a dialogue with your doctor about this and see if you can attempt to have a VBAC, even if you've had one of these special scars.